Good afternoon. So, in locally advanced breast cancer, now mastectomy has been done and the patient has been referred to the radiation oncologist. And the question comes, should we give adjuvant radiotherapy? Yes or no? I think the confusion was created by Dr. Kuzik, and he made a meta-analysis and he found there is no survival advantage with post-mastectomy radiotherapy. And that confusion was there for a pretty 2-decade time. Thereafter, 3 randomized controlled trials came, the Danish 82B, 82C, and the British Columbia trial. The Danish 82B trial was meant for the patients who were premenopausal, high risk, involvement of axillary nodes, more than 5 centimeter tumor size, invasion of the skin and pectoral fascia. The patients were randomized to receive either chemotherapy alone or chemotherapy plus radiation. And the study revealed significant improvement in disease-free survival as well as overall survival. The 82C trial was designed for the patients who were postmenopausal and with tamoxifen, they were received radiation also. And again, post-mastectomy radiation in these patients improved survival both in terms of disease-free survival as well as overall survival. And the results of the British Columbia study, though it was small in size, but it's not different from these two. So, post-mastectomy radiation therapy improved survival in patients who are more than 5 centimeter in size with pectoral fascia or skin involvement and have a nodal positive disease. The evidence was further strengthened by this EBCTCG meta-analysis when they noted that the patients who having a locally advanced breast cancer, node positive disease, even after they receive anthracycline and cyclophosphamide-based chemotherapy, the local regional recurrence and survival both are significantly improved. And what it was noted that 5-year local recurrence risk was reduced from 22.8 to 5.8%. And 15-year breast cancer mortality risk reduced from 60% to 54.7%. And that said that every 4 local recurrence, if you can prevent at 5 years, 1 life can be saved. And that is why you are advocating adjuvant post-mastectomy radiation for these patients. However, questions can be asked that most of the patients were not exposed to taxanes. They have not received perhaps trastuzumab, aromatase inhibitors, and now in this present era, is that data really holds right or not? Maybe there are some limitations of these Danish trials. The median number of nodes they removed was only 7. 255 patients on 82B trial had less than 4 nodes removed. And subsequent retrospective series reported that the recurrence risk that was there in the Danish trials is really higher. And with the contemporary studies, it is not that high. So in the present era, when we can deliver post-mastectomy radiation, perhaps the patient having local regional risk of failure more than 20%, when 4 or more positive axillary lymph nodes, primary tumor size more than 5 centimeter, RT4 disease. In few scenarios like age less than 40 years, histological grade 3, presence of LVSI, less than 6 nodes removed, or extracapsular spread of more than 2 millimeter, they can receive radiation with of debatable benefit. What should be the target volume? If you look at the pattern of failure, after MRM and ALND, chest wall is the most common site, with 50 to 75% patients will fail there, followed by SCF and infraclavicular region, 20 to 40%. So axillary recurrence after a level 1 to axillary lymph node dissection is less than 5% at 10 years. So axilla, if you have addressed properly, is not routinely irradiated in the post-mastectomy setting. However, the internal memory irradiation is debatable, and that will be dealt with by the subsequent speakers. Now, in the era of hypofractionation, we are delivering post-BCS hypofractionation. But is hypofractionation safe post-mastectomy? Though the START trials, some patients, approximately 500 odd patients were post-mastectomy, they received radiation, but the trial did not really make much comment about the safety in the post-mastectomy setting. However, many institutes do practice. In JCO 2007, Dr. Atif Khan et al., they have published their results of a prospective study comparing 36.63 gray in 11 fractions and followed by boost. And they show the toxicity pattern is not very high and it is deliverable. So based on that, 2 randomized trials have been launched. One is the Alliance A221505, the phase 3 trial randomizing hypofractionated post-mastectomy radiation with breast reconstruction up to a dose of 42.56 GY in 16 fractions compared with conventional fractionation. The second is a phase 3 randomized control trial, post-mastectomy hypofractionation radiotherapy in high-risk breast cancer. And that trial is giving 43.5 GY in 15 fractions in 3 weeks, comparing with conventional radiation of 50 gray, 25 fractions over 5 weeks. So we have to wait for at least 5 to 10 years period of time before we come to the results. Coming to the patients post-mastectomy who come with 1 to 3 lymph node positive disease. I think our subsequent speaker will speak on that, so I will not go into that much. But if we look at, here. So the bottom line is that the locoregional recurrence. So if you want in a 1 to 3 node positive patients, if you want to reduce the locoregional recurrence, you have to treat at least 5 patients compared to the 4 patients if you are looking at the endpoint of locoregional recurrence and more than 4 nodes positive disease. Whenever you are looking at the endpoint of death, you need for 1 to 3 node positive disease, you require to treat 1 patient to avoid a death compared to for patients with 4 node positive for 10 patients. If we look at the contemporary result, the 5-year rate of locoregional recurrence is 8.9% without PMRT versus 0% with PMRT in the patients who are having 1 to 3 node positive disease. In 1 to 3 node positive, grade 3 disease and or extracapsular extension, in these scenarios, most of the studies, they hypothesize that perhaps post-mastectomy radiation has a propensity to improve local control and maybe survival. As we know that EBCTCG gives us the best information regarding the parameters, and we can see that EBCTCG meta-analysis says for 1 to 3 node positive patients, if you irradiate the chest wall and the supraclavicular area, we can achieve better locoregional recurrence, reduced locoregional recurrence rate, better disease control, and improved survival. So, and subsequently this has been proven in another meta-analysis, but this is largely for T1, T2 disease. Coming to the patients in, again, that can we avoid treating 1 to 3 node positive patients? Yes, for some patients, the locoregional recurrence risks really outweigh the toxicities. So a patient who is more than 40 to 45 years, a T1 tumor size, no LVSI, single node positive disease, and a small size of nodal metastasis, and substantial response to neoadjuvant chemotherapy, perhaps these patients, even after 1 to 3 node positive, we can avoid giving them radiation. So as you know that majority of our patients getting neoadjuvant chemotherapy, and after neoadjuvant chemotherapy, the situation is more complicated. When to give radiation? Let's look at the recurrence risk. If a patient comes with a 5 centimeter tumor or node positive disease and the patient doesn't achieve a pathological complete response, the recurrence risk is in excess of 20%. And as we discussed in the previous slide, that is perhaps an indication when you should go for radiation. Again, if we look at the molecular factor, the patients who are triple negative disease, they have a higher propensity of locoregional recurrence. And again, it says that perhaps these patients merit adjuvant radiation. If we look at the data from MD Anderson published in 2005, that says that the patients who have skin or nipple involvement, supraclavicular nodal involvement, those who did not receive tamoxifen and who have extracapsular extension and estrogen receptor negative disease, they have 2 to 3-fold higher risk of locoregional disease recurrence in absence of radiation. So if we have out of these factors at more than equal to 3 factors, the recurrence risk is 28% compared to 1 or 2 factors, 4 to 8%. So we have to look at these risk factors and we can stratify our patient because we don't have a level 1 evidence. The subsequent study from the same institute again hypothesized that the patients who do not achieve a complete pathological response, they are at higher risk of developing chest wall recurrence, and those who are having nodal disease residual, they will clinical disease in the nodes, they will have a more chance of nodal disease in the post-chemotherapy specimen. So they should receive adjuvant radiation. There are different nomograms, and you can look at this nomogram that says that the patients who have a clinical disease of more than 5 centimeter, who do not achieve a pathological complete response, they have a higher chance of locoregional recurrence and they merit adjuvant radiation. So in the absence of prospective data, we have this NCDB meta-analysis, and that says that post-mastectomy radiation therapy improves survival if the patient comes in clinical stage 3B, 3C disease, T3, T4 disease to begin with, a residual invasive breast tumor after neoadjuvant chemotherapy, and who has not achieved a pathological complete response. The definition of pathological complete response has emerged a lot, and we must remember now pathological complete response means there should be no evidence of invasive and in situ malignancy both in the breast and the axilla. So very careful whenever we are reading the report, and it's not that only breast is pathological response, complete response, and we avoid radiation. So what should be your portal design? Again, there is no such data. Should we irradiate the internal memory nodes or not? It is a difficult question to answer. We have some trials ongoing, and because now we are going to an era where sentinel lymph node biopsy is coming a big way even after neoadjuvant chemotherapy. So Now, the trials are coming up to say in sentinel lymph node biopsy patients who will receive post-mastectomy radiation. And these are the designs of the NACP-BB51 trial and the Alliance trial. The patients with clinical T1 to T3 disease who will go for sentinel lymph node biopsy, and the sentinel lymph node biopsy positive patients, they will go for further axillary dissection plus radiation or axillary dissection alone. So we have to wait again for 5 to 10 years time before we come to the conclusion that after sentinel lymph node biopsy, when post-neoadjuvant chemotherapy setting, when we should treat them, what is the extent we should treat, should we go for chest wall or should we include chest wall plus IMN plus SCF. So lot many debates is there. So I would like to conclude that post-mastectomy radiation in locally advanced breast cancer improves survival, local control. So we have to look at the patient, though the data is old, but in the present era with modern radiation, toxicity will be less. So the chances of having more toxicity and the benefit being outweighed by the toxicity is less. So we should give post-mastectomy radiation in locally advanced breast cancer. Hypofractionation, though is being evaluated, I feel this is not the standard. We should go for conventional radiation. We should wait for the mature results. In 1, 2, 3 lymph node positive patients, the chest wall plus supraclav should get radiation. Of course, the patients who have lower grade biology, more favorable biology, one can think about avoiding radiation for them. After NHT, it is really a gray area. The patients who have a more than tumor size of 5 centimeter, clinical node positive disease, and those who do not achieve a pathological complete response, they do merit radiation, of course, to the chest wall and to the SCF. The IMN, I leave up to the next speaker to discuss in detail. Thank you for your attention.